We're here at the International AIDS Conference in Cape Town, South Africa, with Reuben Granich, who is the medical officer for HIV/TB department. And we're very pleased that you've taken the time to meet with us. And you have some very specific ideas and perspectives on antiviral treatment or HIV treatment as prevention. Give us the background on yours and the importance of it.
Well, thanks. I really enjoyed being here and having this discussion with you. What we did was a theoretical model, so it was a modeling exercise. And what we did with the model was to actually use the assumption that if people were tested on average about once a year and took ART or treatment, that would actually decrease transmission. And we applied, because we know that ART is actually a very strong suppressor of viral load. And we took that model and we actually applied it to a South African type setting using data from sub-Saharan Africa. And that showed that we could see a 95% reduction in incidence over a very short period of time, a 10-year time period, if we rolled out this model. And what it also included was that people would need to be tested on average once a year and then immediately go on ART irrespective of their CD4 count.
And now, could that translate, how could we translate that into different other areas in other countries? And
we need to be a little bit circumspect about that because it is a model. So it's a theoretical model, and we did use data that was applied to the Southern African type setting. So we haven't modeled what it would be like in the United States. But the basic principles, I think, would hold true for almost any country in terms of ART driving down viral load and suppressing transmission. And those are things that we see in PMTCT. For example, there are very few pediatric AIDS cases in the United States. Most women get on ART. So we're pretty sure of the principles around ART for prevention in terms of stopping transmission. Whether it would work in the United States, I think that's something that's probably best answered by the local public health authorities there.
Every time we put someone on treatment, that is one less person out there probably communicating the virus.
That's the basic principle, and so we need to also keep in mind that right now where we are in the world is we have around 4 million people on treatment. However, in 2007 we know that 2.7 million were infected and 6.7 needed treatment. So we're really not keeping up with the treatment demand. So we need to actually we need to do something to prevent transmission, and also we also know that by placing people on treatment is exactly as you said, when they're on treatment, if they're adherent to the drugs, then transmission goes down to a very, very low level. So on a population level, it makes sense both from a prevention perspective and also from a treatment perspective to place people on ART.
But will they be willing to commit a lifetime, presumably, of treatment, even if it's one pill a day, and you know, for the rest of their life, and see that as a goal to reducing the population problems?
Well, that's actually a great question. So you have to, I think you have to think about the population divided up a bit. For everybody less than, let's say less than 350, or depending on your local guidelines, for everybody less than 200 or less than 250 or less than 350, depending on where what your guidelines say, those people need to go on treatment for treatment itself. So in other words, to stop tuberculosis, and you know, and that level is actually probably creeping up on some level. The IAS guidelines in the United States are more liberal. In places where resource constrained, it's a little bit more restrictive. So, so everybody under that level should actually be on treatment just for health's sake, let's say. Now, people above that level, those are the ones that you're talking about where it's actually a decision on some level. Is this going to benefit me? What's interesting is that we're starting to think or see some evidence from this conference that actually starting earlier, even above the 500 level, may confer some benefits, and that HIV may be a chronic inflammatory disease, and that there may be benefits from starting earlier. So the question mark, it really is for the people that are above 500, let's say, or above 350, how long before that time would there actually not be both benefits for the community and for them? And then you're absolutely right, there's going to be a certain number of people where they're taking a medication over a long term, and the first couple of years that they take that medication, let's say, is going to be probably for the benefit of their partner so they don't transmit HIV to them, or the benefit of the community. What that time period is, I think, is of some question, and over time we'll understand more. We need to do more research to determine that. But my sense is that we're heading to an era where people will, and in the United States I think this is the way it goes, is that it's starting to happen, is that people will make the decision to go on therapy when they're ready, and when the benefit works out for them in terms of both morbidity and also in terms of being sick, getting sick, and also in terms of transmission. Now, I would say that in the developing world, the resources are so constrained that we don't have the luxury. I mean, it's very luxurious to talk about going on when you're ready. There's waiting lists, and the economics are quite bad in terms of supplying treatment.
Yeah, the thing that I guess I was worrying about is whether when you evolve the learning through this learning process, whether we'll have the resources and the willingness to commit to this in a practical way.
Yes, and I think the thing to reemphasize is that this is a theoretical model, so we're modeling, and modeling helps us understand what we need to know, what we don't know, and we need to look at those sorts of issues as well. We need to look at long-term adherence, we need to look at supply chain, we need to look at feasibility, will communities accept this? And then when you get to the resource issue, we did a very rough costing, and here's the interesting thing is that costs for HIV/AIDS will increase in the near future, and they will continue to go up. As more and more people have HIV, they will become sick. The costs will be there.
So we need to reduce the growth rate.
Right. So the question for policymakers, and it's a question in the future on some level, but the question will be the one that we need to answer is that: is it worth putting more people on therapy now in order to get the prevention benefit that you may see later, to kind of spend our way out of this situation, or are we just willing to continue to have to pay over the long term? And obviously we haven't done the in-depth economic analysis, otherwise I would have presented that, but that's something that we need to do from a research perspective. What is the cost benefit, and how much would we have to invest up front to actually get out of the business of having to supply treatment to so many people for so long, which may or may not be sustainable in our current, financial situation.
And the thing that I was mostly concerned about in the old days, I think all of us were, is that treating early was something that people did. No virus is good virus. That was back in the early days. And then we realized the drugs were somewhat toxic, so you had that as a problem.
Yes.
And I think now today we see that as less of a problem, and there's less pushback on people. People are actually more anxious to get on treatment today because it looks not too difficult to take. So that's maybe an attractive
well, you've exactly captured it. I mean, if you have drugs that are that have high levels of side effects and are difficult to take, and I mean, you remember back in the day how difficult some of the early medications were to take. Yeah, very, very difficult. Now we have a whole, many new classes, etc. It's getting much like it's never easy to take medications, and it's not. I don't want to diminish that burden, but it's actually much easier. Now, it's much easier for people in the north. People in the south are getting different regimens. They're not getting the new classes. But the point being is that at some point there's going to be a convergence where the new medications will be actually far more tolerable once a day, this sort of thing, and then people will also, that will help them with their decision making regarding when they should start therapy.
So what are your next efforts? What are your next steps that you're going to be taking in the position that you?
Yeah, this again, a theoretical model is bringing together what we know from a number of different fields: HIV testing, virology, drug development, regimens. Also from a human rights perspective, community participation. We've drawn on all of that information to put the model together in our thinking. But it's only a theoretical model. So now what we need to do, WHO is a member state organization, and we will pull together all of our stakeholders, and there's many of them, but they're the scientists, they're the community members, there are people living with HIV, there are human rights people, and we're going to pull together those people from the world, because it's a global issue. We'll pull them together in a meeting in November, and we'll discuss the model, we'll critique it, we'll see some problem areas, we'll discuss the challenges and these sorts of things, and hopefully we'll come up with a roadmap for the next few years, what research needs to be done to possibly inform policy in the future.